Hello everybody, my name is Hinam Park, Yonsei University, Severance Cardiovascular Hospital, Seoul in South Korea. I'm glad to have you, all of you, to this educational video clip. I would like to talk about the procedure itself slowly, and I would like to say the hidden secret tips one by one. So I hope everybody will enjoy this session. The first question is, what is the mechanism of atrial fibrillation? Atrial fibrillation is a very complicated mechanism, but as an electrophysiologist, if you don't understand the mechanism of atrial fibrillation in detail, it is very hard to apply your technique to very diverse and complicated patients. So first of all, you need to keep in mind that there's two different mechanisms of atrial fibrillation. First one is trigger mechanism, and second one is maintenance mechanism. Even though some people has frequent atrial premature beat, if it doesn't sustain as a fibrillation, the patient never have atrial fibrillation, only skipping beats and APC. And second one is, even if the patient has some substrate, if there is no APC, there is no atrial fibrillation. So you need to divide the mechanism of atrial fibrillation. Number one, trigger mechanism. Number two, maintenance mechanism. And traditionally, basic scientists, electrophysiologists, classify the maintenance mechanism of atrial fibrillation as two classes. One of them is the focal source mechanism. So there is some fibrillating focus or rotor maintains atrial fibrillation. And another part of basic electrophysiologists say that there is a multiple wavelet hypothesis. There is no focal source, but if there is significant substrate and the critical mass, so-called, in other words, if the size of atrium is big, atrial fibrillation can maintain with continuous wave break. So the maintenance mechanism of atrial fibrillation is a focal source and the substrate, that is multiple wavelet hypothesis. So in Yonsei University, the Severance Hospital strategy for the proximal atrial fibrillation is that there's no doubt about the pulmonary vein isolation is very, very important. Most important, the parasympathetic ganglia innervate to the heart is on the third fat pad. It locates at the beside of SVC junction and the aorta, this area. So we ablate from SVC to fossa ovale by linear ablation in right side. Also, there is another fat pad at the base of, this is IVC, coronary sinus is here, and this is middle cardiac bed. There is another big parasympathetic fat pad. So we try to ablate this area, so that's why that is another rationale to ablate the cable tricuspid isthmus ablation in our lab. So for the patient with proximal atrial fibrillation, our basic ablation lesion set is PV isolation and SP septal line and cable tricuspid isthmus ablation. Of course, there is some strategy, but my institution continue the same strategy for proximal AP. For the persistent AP patients, there is so many diverse trial to improve the rhythm outcome of persistent atrial fibrillation. But nowadays, there is no consensus for the circumferential PV isolation is important, but in additional linear ablation, cafe ablation, rotor ablation, any other kind of ablation is just a 2B indication and the guidelines. So last 10 years, we try to make a linear ablation in so many patients. For example, posterior box isolation and anterior linear ablation. But after the randomized clinical trials and the retrospective studies, the linear ablation did not improve the rhythm outcome in patients with persistent AP. That is the laboratory data. Of course, there is some subpopulation who improved the outcome of catheter ablation after linear ablations. However, in general, the additional linear ablation was not beneficial for the patient who was persistent AP. The only thing we found the beneficial for the patient with persistent AP is the After PV isolation, if there is an extra PV trigger, it is quite helpful. It can reduce their recurrence rate. So after, regardless of paroxysmal persistent atrial fibrillation, we try to induce atrial fibrillation again by isoproterenal provocation, and then we give a cardioversion. If there is a trigger or frequent APC, we try to ablate them all.